Good evening, everyone. Let me first start this session by thanking Economic Times for organizing this event commemorating the Doctors' Day. And I would like to express on behalf of, I'm sure, everyone, our deep sense of gratitude and thanks to the entire community of doctors, supported ably by the nurses and the allied healthcare workers who have protected us during the last 2 to 3 years of the pandemic. It's because of their tireless work, selfless sacrifice, and the commitments as a nation, I think we have handled this pandemic better than many others. So a sincere debt of gratitude and thank you, everyone. The topic of this panel is, the panel discussion is Global Health Emergencies and Beyond, tackling evolving challenges through right mix of technologies and best health practices. We have a very eminent panel here. I'm not, for the brevity of time, I'm not going and introducing them individually. Their introductions are in your dossiers. What are we going to talk about here very briefly in 30 seconds? Any emergency is a very large shock to existing health system. Particularly for healthcare, it means you have to look after the existing patients, and because of the emergencies, you will have a very large set of capacity that is required over a very small period of time. To deal with emergencies, there is a need for advanced preparations, particularly around surveillance, digital technologies, adoption of sustainable tools, processes, protocols, building rapid capacities. And many of these preparedness for India has been tested over the last 2 to 3 years. So the topic of this panel is, what did we learn from it? Which will help us in the rest of the pandemic as well as the road ahead. To talk about it, we have the entire panel discussions. I'll first go to Dr. Aayog, really in terms of understanding, maybe the question specifically to you, Aayog, is, the health system in India is extremely fragmented. Any way you look at it, from a delivery, financing, governance perspective. Let's talk about digital health for a minute. What role do you think digital health can and has played in bringing these different disparate elements into one place so that we can have a more effective and pointed response to the pandemic? Over to you.
Thank you, Siddhartha. Thank you for having me, NITI. On the panel, I seem to be representing the private sector here. We're eminent panelists from the government, but that's what makes it interesting. Healthcare, wherever we've seen in the world, wherever healthcare is good, it's always been a balance of good public health and good private sector working together. I think that forms the basis. And in our country, we are still catching up on public-private partnerships in the real sense. But what we really saw in this pandemic is something which we would have wanted to work for last few decades of PPP policies suddenly fructified. We all seemed to be a tipping point that was required for us to go through COVID to see such wonderful partnerships happening. Digital is something that is inevitable. Whether it's private sector or public, one weakness in our country has been our capturing of statistics and data, which has been our weakness that's at large. I come from east of India, 26% of the population that we cater to, and we have almost just one bed for about 3,000 people, which is 3 times worse than the country's average today. But beyond that, if you ask me, what's my, how do we plan our entire budget for, say, the state of West Bengal or east of India towards catering of NCDs or CDs, how do we distribute? Can I forecast my dependencies in terms of how many stroke patients do I need to cater to in a state, or how many oncology patients are we expecting to be treated? How many centers do we need in terms of cancer centers from a NCD point of view, which is what we are dabbling with today. Not that the communicable diseases are left behind, but I'm saying statistically we are not equipped enough to be able to plan for such forecasting such demand so that we can plan. And I'm talking of planning. pandemics don't give you time to plan. Pandemics just hit you just when you're not prepared. And we saw it during COVID. And that's when all this data really, really comes to hand, and which we didn't have this time around. Getting into details of it, we would look at it. But today, if we can have data even congregated from whatever data we have available with us, and the National Health System's digital mission, which is started off, is a music to, I think, everybody from rural India to urban. If we can start sharing data without worrying that what happens to my data, how is it being used, that's a real magic that's going to happen, and we'll be a long, long way ahead. Thank you, Siddhartha.
Thank you for that, Ayanab. Let me move to Dr. Guleria. Epidemic resilience requires a very well thought out policy and a regulatory framework which defines for all the stakeholders the roles they need to play in a synchronized fashion. In your opinion, sir, how has this evolved? How has the thinking of this evolved during the pandemic? And what lessons this may have for us in the future? Thank you.
So I think this is something which is very important. And the reason why I say this is that this century has been a century of outbreaks and pandemics. We've had a lot of outbreaks and pandemics in the last 22 years. We started off with H5N1, which is known as bird flu, and that luckily did not become a human virus, but has a case fatality of 60%. We had SARS, we've had MERS, we've had one previous pandemic, the H1N1 pandemic, which was known as swine flu, and we've had outbreaks of Zika, Ebola. So there is a need now to really plan and have a model for future outbreaks, because that is what seems to be happening. And this is something which is related to multiple factors, the environment. The whole concept of One Health becomes very important, because all of this is because of viruses jumping species and causing human-to-human spread. Therefore, we need to have a plan where we do surveillance, which is not only from the point of view of humans, but maybe from animal point of view also. Also develop a strategy of how do we upscale our resources. In a large part of the developing world, we already are stretched as far as resources in the health sector are concerned. So we can't build a hospital and keep it empty saying that, when there is an outbreak, we will use it for an outbreak management hospital. We will have to see how can we repurpose our existing facilities to manage an outbreak, but also how can we contain it so that it doesn't reach the stage that the pandemic reached this time. For that, we need to have surveillance with good genome sequencing. There has to be a whole sector of individuals who are involved in public health and surveillance, who can look at not only the surveillance part, but its clinical epidemiological link. So if someone sitting in a small area suddenly observes that there is a cluster of cases which are atypical, he should have that awareness to report it to the authorities, take necessary steps, and be able to contain it. It's possible, it's not that it's not possible. We've seen that in the south. We had an outbreak of Nipah virus, and that was contained very effectively because someone thought that this could be sort of a new viral infection. It was tested and it was contained. But that type of strategy needs to be planned at a national level, at an international level. So surveillance linked with the epidemiological and clinical profile, and how do we then have a plan of action in place, which is local, regional, but also national and international. Unless we do that, we will continue to have outbreaks. And we'll have outbreaks which will travel from one part of the world to the other. We're already talking of an outbreak of monkeypox. So this is something that this century is seeing and will continue to see.
Very, very well said, sir. This is not the last pandemic we have seen. There are many, many others possibly ahead of us, and we just need to make our systems more resilient and robust. Moving on to Professor Jayalal, we all know that India's the healthcare infrastructure, the technical manpower, doctor pool, compared to the patients is stretched at the very least. But suddenly you had this pandemic where beyond treating existing patient load, doctors had to come up for a protracted period and handle a very, a pretty significant global pandemic over a pretty long period of time. So significant amount of fatigue, stress, And the fact that they had to manage very large organizations as well as patients were really frightened, not knowing what this pandemic has in hold. What are some of the new skill sets do you think the doctor community has picked up, and how this is going to help us, build a more resilient system in future?
Yeah, thank you very much. Yeah, unfortunately or fortunately, the medical education, most of the time we give much importance to the cognitive skills. The aptitude and the communication skills or the outcome modules were not given much priority. Now, this pandemic has taught the people, it is not only your cognitive skills are going to help you, how you are going to interact with the people, how you are seeing the communication, how your attitude of meeting the people, even when you are knowing that you are going to die with the infection, but still the courage with which that you are able to go there. So these skills were now inculcated into the minds of the people. I'm sure the NMC is also taking a step on that. So instead of just focusing on more on the cognitive, but more on the skills and the psychomotor domain, and that is the most important thing. The second important area where we need, unfortunately, again, there is a much hype on the clinical subjects. If a medical student is coming into that, he will be right to go for the cardiology, or he will be going for the surgery or the medicine. But the family medicine and emergency medicine, which are the two important subjects which is needed to cater to the peoples when there is a disastrous happening in the society or when a community help is needed. So we need to have these two departments, or the people of specializing on the comprehensive treatment of the family medicine, or the on-spot and the emergency care treatment physician. Unfortunately, in our undergraduate education system, there is no department of emergency medicine or department of family medicine existing in medical colleges, with which the undergraduate is not exposed. So unless he is exposed to such a department, it will not be possible for him to choose this as an option for his post-graduation. So now, fortunately, NMC is insisting that emergency medicine, the casualty should be converted to the emergency medicine. The concept of emergency medicine and the pre-hospital care medicine is coming into play. And I wish that more of the family medicine concept should be also incorporated into the medical education, the skill. Then the people will have the cost-effective, community-oriented, continuous care will be, that will be helping us. The third, the capacity building, when we always talk about the doctor as the capacity building increase, we talk about the number of doctors. But the associated healthcare professionals or the allied health professionals, the paramedical people, available for the number of doctors. Now today we are going to the level of nearly 96,000 MBBS graduates are coming out every year. But the last 10 years, there is no drastic improvement in the paramedical people, number of people coming out of that. So that has to be also to help the doctor, to help him. The doctor cannot be put into all the other unnecessary work if he is going to concentrate on the medical related. Other work has to be done with the supportive staff. So that integration has to be created. Then if we can build this together, I think definitely we will be able to do that. Finally, we always have the medical profession as a two complementary area conundrums. One is evidence-based medicine, another is an experience-based medicine. Though we say it is a modern medicine, but still in many parts of the areas, people talk about experience-based or the experience-based medicine. The evidence-based medicine, the algorithm-based medicine, or the supportive medicine, probably institute like AIIMS or institute like the Higher Institute, they follow a process-centered practice. But many areas in the villages, it is a person-centered medicine has been created. So we need to make the personalized medicine, but not doctor-centered, but it's a process-centered medicine. The skill which has to be the quality-oriented skill, if it comes a process-oriented medical care, I think that will add on to the meeting out to this. Because this COVID, in every part, hundreds of modules of treatments were followed. Only the second wave, with the AIIMS and Ministry of Health, we could be able to do a standardized protocol. So this kind of a standardized protocol system, a standardized skill or process-based skill has to be created. That for all the associations, ministry and the institutes like AIIMS has to work together so that we will be able to achieve those things.
Great answer. Many areas, very interesting thoughts. It's a multi-pronged approach, not one that is going to solve. Moving on, Dr. Madan Gopal, we are very privileged to have you from NITI Aayog. Right within the first, I remember, in the first week or 10 days of when COVID-19 was still at the borders and it hadn't entered India. NITI Aayog played a very important role in really, removing the roadblocks for launch of telemedicine, EICUs, remote monitoring. Many of these areas that required a legislative and a regulatory nod were made possible. And we all know in the last 2-3 years, all of us have been beneficiaries of that. To what extent these steps, in your opinion, have shaped our response to the pandemic? And can you help us, gaze into the crystal and say what lies ahead?
Thank you, Siddhartha. One of the interesting aspects when we were caught in the mist during the first wave was lockdown was there, and whole of the fraternity was not sure that what kind of treatment modality is to be adopted. Apart from that, fear and other things were there. And the lockdown was there, and we have all witnessed that. During that lockdown, because we had that disease burden of your communicable and non-communicable disease. We have been talking about non-communicable disease, and during this lockdown phase, when most of the hospitals, private hospitals, were shut and some of them were taken over by the government for providing COVID services, there was an issue that how to provide continuum of care to this non-communicable, the persons who require a follow-up care and the medical care. Telemedicine was there in this country since the early part of this century, but honorable courts, they have taken and cognizance of that, and they have passed orders against the doctors doing teleconsultations and other things. So to assist them during this time of that, it was an opportune time. And at that time, fortunately, our honorable member was wearing two hats. One was the hat of the Board of Governors, chairperson of Board of Governors for MCI, and he was honorable member of NITI Aayog. So with the support of the Board of Governors, I think Dr. Guleria is already there as part of the member of the Board of Governors. Then it was an opportune time to at least provide some guidelines which can give and strengthen the hands of the doctors in providing teleconsultation and other things. And we have seen that how beautifully we have managed the second wave when the virus outpaced our preparations and our activities. Where the system was overwhelmed for 15-20 days, and you see that how the home care, the assistance of the digital technologies, we never thought about that we could be managing the patients in the home care settings using a small digital device, the temperature thermometer as well as your pulse oximeter, assisted by the teleconsultation, other thing, because that has given us strength to provide treatment. So a legal backing was given. And you see that how we managed that 15-20 days where the system was overwhelmed. And apart from that, when the telemedicine guidelines were released at that time, we were conscious of the fact that they are not sacrosanct. And it will evolve as the system will get mature and the people would be using it, it will evolve. Now it is evolving. Now new guidelines would be coming up. So people are working on that. You will see that more precision will be added to that. These are the things which have evolved during this time, and we have seen that how we have been able to structure our treatment protocols accordingly. And one of the important segments which is coming up in the country is the home care segment. And you see that how this telemedicine guideline, which has provided some strength to the legality of our consultation, other things, how it can evolve. That home care is evolving. The senior care is also evolving because in the next 15-20 years, you would be having a problem of providing geriatric and senior care. So you see that how this guidelines would be aiding in managing all this care. So it is evolving. It has opened a market for this, but there are many challenges. One of the challenges to see that how this teleconsultation, they can become a referral and the person can get an assured linkage in a particular hospital. Can we provide a standardized teleconsultation, because we are having many platforms? Can we think about Uberization of this platform so that a consultation is available 24/7? How to address the harassment to the doctors and the person providing telemedicine? There are many issues. A lot of things will evolve in the coming days. We have to create standards and see that how things evolve. Regulation is the answer which will come later on, but we have to first see how the things evolve, mature, and where people start using it, setting standards for themselves, and see that how the linkage for continuum of care from consultation to provision of care can happen. During the COVID time, we have seen after teleconsultation, bluntly the person was referred to the hospital. Now you require hospitalization. Without saying that which hospital to go, whether they will get the bed or not. We have to see that if we are able to connect these two points, then that means we have cracked the issue of providing continuum of care through telemedicine. I will stop here.
Absolutely. Thank you so much. What you have just said has enormous implications for chronic diseases, NCDs, remote cares, and very, very important. I think it's not going to be wrong to say in the last 2-3 years, India has leapfrogged by about at least a few decades in digital health. Moving on to Dr. Suresh Kumar, last but not the very least, very important questions. How do you build new infrastructure, whether it is diagnostic, surveillance, or even delivery infrastructure? Knowing you never know when a pandemic is going to strike, but how do you build it and keep that capacity with you? What are some of your thoughts?
Thank you, sir. Privileged to be part of this esteemed panel, and happy doctors to all of you. I am representing Maulana Azad Medical College and largest COVID hospital of the country. We had 2,000 bedded exclusively COVID facility, and we have till date treated around 25,000 patients, highest in the country. We had 800 deliveries in COVID positive mothers, 3,500 dialysis, and we have seen the big challenge in last 2 years when we were facing the first wave, and last year the second very severe wave, and we have seen that a lot of big challenge in diagnostics, particularly in the molecular diagnostics. And we have seen that initially when RT-PCR report we were sending, and report were coming on 3rd day, 4th day, and we were waiting for patient to become negative so that we can discharge after the 10 day or 12 day. So we have seen over the last 2 years that we need to have a robust diagnostics, particularly the molecular techniques labs, which we have seen that large medical colleges, the premier institute like AIIMS and other big centers, even in the corporate, we don't have the molecular techniques, and we have less manpower, trained manpower. So we need to relook at the national level that how we can make a effort to have more availability of services at the district level, at taluka level, at the village level. We have seen that there is enough scope of public-private partnership. We have enough space, and we have seen that in the government medical college, the trained manpower is not there. We have space, but we have seen that successful model in managing the hepatitis C program. You all know that hepatitis C is now curable with just 3 months of therapy, and we need to have a HCV-RNA molecular labs. Now we are doing a lot of work in the other areas also, not only the virology, but in the other areas where we can have the public hospital and private partners, and they can help greatly in the managing the big problem of a pandemic of this size, that we have the online services, we have the supply chain, we have the IT services, and we have other ecosystem which can help our rural areas, our big great cities where we need to have more partnership with all the teamwork. So it is important that government is doing its efforts, as Madam Patel has just discussed, that a lot of work is going on under AAIMS Bharat, that people are having free services even at the rural area. So we need to have more and more efforts at the periphery, and most of these services are urban oriented, where a lot of people are spending out of their pocket in the rural area, and they don't have access to free medicine, free diagnostics. Think about the molecular techniques. So Professor Guleria has rightly said that we need more and more robust mechanism to fight the new challenges in the healthcare system.
Thank you. So you've touched upon a number of very important points: public-private partnerships, need for molecular diagnostics, better surveillance infrastructure. Let me turn to Ayanab. What are some of your thoughts in the way we can optimize the existing infrastructure? Ultimately, whether it's a bed saved is a bed earned. And what role does integrating these infrastructure elements with real-time data analytics, how can it yield better productivity and throughput, especially at a time when you need it desperately?
Yeah, I mean, it's honestly, the answer is in the question, Siddhartha. I mean, there is no two thoughts on it. The challenge has been, I mean, if you even look at when the pandemic broke out, the initial days, I remember, I mean, there was a lot of chaos all around. Policymakers also had to take their time to come along. We would treat patients suspecting they were COVID, and the test would have to go to a government lab for which they were overwhelmed with those number of tests. So the report would come about 3-4 days later, but then we would anyways be treating. And this was the first few weeks of treatment of COVID. And then we realized there were a lot of hospitals which already had RT-PCR facilities available in the government's private sector. But then again, it took time for us to understand that can you allow them to do the test. Third layer was there were enough IVF labs all over the country who all had genomic testing capacities and RT-PCRs available. But then again, we probably in the second wave, by the time it came up, we had integrated all of these into our network. So today, at the end of 2 years, we have a solid database of all labs in the country, state by state, city by city, which actually does RT-PCR. Now, we need probably Dr. Guleria's help to figure out what are the next pandemics, what will the tests required, do such mapping right in the beginning, keep it ready, so that we are ready when the time comes, we don't lose those first 2-3 weeks trying to figure out what we did. Give a small example, Siddhartha. This is in Spain, Alzira model, where they actually have mapped out. It's a prototype case study. If you look it up, the private sector handles a few provinces, government handles a few provinces. What they did is the entire population is mapped, population age-wise, sex-wise, disease-wise. So when the pandemic hit them, they actually knew how many hypertensives are in that area, how many people, what are the comorbidities. They could factor in address-wise. And then accordingly, they categorize the entire city or the province from a treatment point of view. And the response to COVID in those provinces were phenomenally better than where we saw they were not done. I mean, it's very ideal scenario. Spain, Algeria is a very developed, but we can start such pilots where we can get into these databases creation, and eventually this is what will make all the difference in how we plan our database. And again, private-public private partnership to me is a solution which we need to work towards integrating and leveraging each other's possible. Thank you very much.
Great answer. Dr. Guleria, as head of India's premier education institute in healthcare, capacity building and creating flex capacity. I'm sure there are some very good innovations that played out in the last 2-3 years. India always had great protocols, but ultimately delivering healthcare would require a large burst of capacity at infrastructure, manpower, to be directed at a large segment of the population. Can you share with us some thoughts and what were some of those innovations that we adopted?
So I think some of them have been discussed, and I think, yes, it's a big challenge because there is a disparity as far as healthcare is concerned, both in urban and rural India. And we need to see how we can reach out and be able to provide comprehensive care across the board. Now, one solution that really came out during the pandemic was telemedicine and teleconsultation, and like you said, EICUs. You could manage a patient sitting here in a smaller town by giving advice to the doctor there, being able to see the database. You could even see the CT scan on your phone and be able to manage the patient. So that is one way that one could see expansion as far as healthcare is concerned and increase its reach to rural part of the country or to smaller cities. But we also need to have a solid sort of base as far as manpower is concerned. And there is a lot of steps are being done in that direction. Many new medical colleges are coming up. Only caveat being that as you have more and more medical colleges, you must also make sure that the quality is maintained as you increase the quantity. So that is something that we need to make sure. But here again, you can use various modules as far as imparting education is concerned. This was done again during the pandemic. So many webinars were organized which could be seen across the country in terms of management, in terms of how to manage various situations, pregnancy and things like that. So one could actually make modules which could be transmitted to all medical colleges in terms of learning, in terms of training. Simulation has come up in a big way. And therefore, there is going to be a lot of technology which will help in training and try and sort of find a balance between the human resources that you need and what technology can do in terms of training and providing good quality physicians as far as the future is concerned. Another thing that I think is important is that there has to be task sharing and task shifting, because it's important for us to understand that we are underutilizing a large part of our health force, which is not doctors per se. We could have nurse practitioners, we could have nurses that could be involved in primary care, and that would help. And that would actually give more time for physicians to be focused on patient care to a large extent. So how do we really develop a task force which is a team rather than just a physician, where the nursing community, other healthcare workers, the technicians can all be involved, and they can therefore be given the responsibility, be given the the guidance to really manage patients and thereby increase your workforce. So strategies to increase your workforce, strategies to get in technology, telemedicine, e-ICUs, webinars to increase the knowledge base, and also accept the fact that in the future we are going to have a huge shift as far as healthcare is concerned. We are already looking at wearable devices. You can monitor patients remotely. All of us would have Fitbits and devices which will tell us your heart rate, your pulse, your saturation. Medicine is going to evolve in the future with the fourth industrial revolution in this direction. And we are going to see a lot of technology coming in. We're already talking of virtual reality, artificial intelligence. So I think we have to embrace all of this, but do it in a manner that it's patient-centric, and it's something which is affordable and available to everyone, be it urban India or rural India.
Sir, in the last couple of minutes, you have traveled, take us 1,000 miles, into the future. Very, very, very insightful comments. Dr. Jayalal, green health and sustainability. There are multiple dimensions to this, right? And over the period of COVID, it reinforced that sustainable health is the only long-term health. And it's sustainable, has to be sustainable for the patient, the delivery system, for the policymakers, ultimately for the entire ecosystem. To what extent are some of the innovative practices, either in public or private, that we have adopted in the last 2-3 years, and how will this play a role in shaping healthcare in the road ahead?
Yeah, the word sustainable health is most important, because most of the time in the epidemic and we go for a knee-jerk reaction and which is landing up in our trouble. When the NCD was thought as a major disease, all of the infectious wards were closed and everything is more put on the head injury and NCD diseases. But if you can maintain the system of a disease pattern which we are having, the old system of infectious disease system which is maintained in the hospitals, if it would have been there, it definitely would have been much easier for us to be there in the pandemic. Now in this system, one of the area where we all find difficulty was an oxygen. And now we have the hospitals as adapted to produce their own oxygen system into that area. The green care energy system has come into that hospital. The waste which is coming out of is utilized for the sustaining all the nutrition, the laundry purpose, and this. So, lot of innovative technology on the sustainability of the hospital, the self-run. And big hospitals and the corporate hospitals can run their own canteen, their own laundry system, their own even the things to be produced. So all this is a part of the sustainable system which is maintained. But the most important thing which we need to have is the sustainability of the doctors themselves. The manpower itself. We, as rightly put by Dr. Guleria, sir, it is not the quantity, it is the quality. The skewed distribution has to be there. Third, the doctors should be provided some safe atmosphere. Today, the major problem every doctor feels is, and when someone is going to attack me or when someone is going to fight the case on me, so that fear complex with this is there. And if you want to work the positive-minded doctor to work in this country with all set forth his knowledge and skill putting forth in a common platform, he should be given an option that he will be protected. You will have a safe environment to work. If somebody is going to file you on the court and there will be the government or somebody to support you, that system is there. Because which is lacking in this country when 1,700 doctors died more than in the COVID. And we do not have a data of that. The government do not have a data of the how many people died and how many compensation we are going to give. So what I feel when we are talking about the sustainability on the infrastructure, sustainability of the hospital, but the most important is the manpower sustainability. The manpower sustainability in the form of the full-hearted involvement which they are going to use. That can become only when all of us, all the stakeholders, both the government and everybody has to come together and see hospital as a protected zone. Hospital as has to be protected by all means. So if that kind of atmosphere, sustainability, if we can build up, definitely we will be good that we will go into that. With the technology advancement, with the telemedicine, the computer based and the solar energy and the energy created, definitely we will be going far ahead in maintaining the infrastructure. But I am still afraid, still fear, and how our doctors are going to be protected, safeguarded, and given a good atmosphere for us to work. And if that human manpower is not sustained, and whatever we talk on the sustainability of the infrastructure is not going to be of any effect. So my appeal, because this is the first time we are seeing, usually the Doctors' Day will be celebrated with the doctors. But today the community is coming forward, Economic Times is coming forward to celebrate the Doctors' Day and applaud us on the back. And this kind of protection and the sustainability is coming from the society. I think that will be the fine day for the medical profession to go forward.
Very well put. Every stakeholder should put in what they take back, and it has to be in harmony for the system to survive. Dr. Madan Gopalji, one of the very important facets, the state responses. States have been at the forefront of the response to the pandemic. And there has been a large role that information and command and control has played in terms of learning from one state, applying that lesson very quickly elsewhere. Can you give us some insights into how this played out and what role NITI Aayog did to facilitate that diffusion of that good practices in a real-time manner?
Siddhartha, this is a very important question. You see the transition from war rooms to command centers. This pandemic has taught us to move away from the war room concept to the command centers. And most of the states you will be finding command centers for COVID management, right from the center to the state. At the district level also, you would be having command centers. So we have transition from that concept of war rooms to the command center. Having said this, if you look at how the information was managed, because when the pandemic started, we were grabbing that key whether the resources which are there would be adequate to meet our requirements or not. So with the help, because it cannot be a single organization job, it has to be worked continuously with the different organization departments which are part for implementing this pandemic. One of the important thing was information sharing. You see how the information was shared beautifully between the labs and the ministry, from the field to the ministry, and you see that the dashboard is still working. Though people will say that the information is not that dynamic, but if you follow that, track it, some of the many organizations now they are doing web scraping and they are finding that the data which is coming that is useful. And first time you have seen that the crowdsourced initiatives for data capturing using the bots and other technology they have used. And the crowdsourced information, the website which they were maintaining and the sites which were maintained at the ministry site, the information more or less are near to each other. There is not much difference in the data which has been available on the site as well as the data reported by the other portal, the crowdsourced initiative. All this information has been collected at the other international levels also, and there is a very less difference between the sites which have been using this data. So that's one of the important thing. And at the time of, because as we are saying command centers are having a different role. They collect the information, they synthesize it, they're having a team of people who synthesize the data and take corrective actions. We do have a system, as we have been talking about the resilience of the system. Resilience means Do we have the buffer capacity or not? Do we have standard operating protocols or not? We do have a integrated disease surveillance program, which is almost 25 years now, and that is going strong. And that has created structures. The structures right up to the peripheral most unit, that is at the village level also, you are having some structure which can collect information and send that information to the central level. And that kind of mechanism is there. For any epidemiological approach, we were having two acts, that is, it's a quite dated act, that is 1897 act, which was revoked for managing this pandemic, and that was amended in 2020 for giving it more powers. Along with that, the National Disaster Act was invoked so that more powers are there and some response is given. So the information collected was more or less streamlined, and it was seamless information which was coming. But the main problem was either to fight with the pandemic or just feed in the information so that the decision can be taken. But this was also handled with the support of the few agencies which came in, and they supplied with the information. And they started analyzing, because the team which is firefighting, they can't be analyzing the information and giving insights and doing the course corrections. Apart from that, you see that logistics software also been made. They were developed in no time. That means if so many numbers of cases are there, how many ventilators, what kind of requirements is there, that kind of analysis used to happen automatically. Had it not been this kind of information, you see that the oxygen, how we have managed the oxygen crisis, where whole of the world was using their military for transportation of corpse and the dead bodies, but we have used the military aircraft for transportation of our empty containers so that we reduce the time. This was only made possible with the availability of information. What is the time lag for the refilling of this? During the 15-20 days where the system was overwhelmed, you have seen a lot of innovation. This could only be possible because of sharing of information. That information, everybody talks about that we will be using AI. For AI and running everything, we have to focus on generating a standard and quality information. But now we have understood the importance of this information. You have seen, and most of them, they have done analysis this time, using the information which is available. You see, many of the agencies or the websites, they would be using this information which are available, and they can do a lot of analysis based on that. So in that way, you have seen how the system has evolved and is going to stay. And if you talk about, there was a mention about the digital mission. You have many systems in the health department. Yesterday evening also, during a course of panel discussion, this thought came up. That means for the TB program, and I'm just citing an example of RCH program and the TB program. A woman, if she is TB, the TB program collects that information, but the RCH, or for the RCH program, she becomes a high risk. How these two data sets can talk to each other? Here comes the role of ABA. I think it's a separate discussions altogether. But you see that the information sharing, how it can transform the war room concept to a command center concept, so that things happens in a very smoother way. So I will stop here. I think I've been able to.
So I think the last question, I mean, in the interest of time, Dr. Suresh Kumar. Ultimately, the last mile delivery of healthcare, India is not only in the cities and tier 1 and tier 2 cities or tier 3 cities, it's ultimately in rural India. And the last mile delivery of services, what role do you think public and private together can play? What would be some of the thematic areas which is going to be good to explore in the road ahead? And what have we learned in terms of public-private partnerships in the last few years?
I think this is a very important question, and Madam Anupriya Patel has just discussed in her remark that to reach the healthcare delivery at the village level, that is the key for the success of the overall healthcare delivery system. And we have seen that most of these areas in the metros and big cities, we have 70% of doctor populations serves. But in the rural area, we are lacking. We need to do more hard work We need to have more aggressive approach, and our services must be affordable, accessible, and freely available. We have seen that in last 2 years that many of the patients refer to us from the rural area. They don't know where to go, how to get the test done. And we have seen that there's enough scope of public-private partnership. In second wave, we have seen that lot of CSR funds were available to us, and we could manage enough funds to have our gene sequencing lab supported by CSR fund, and we could do also the dialysis and other things with the public-private partnership for COVID pandemic. Similarly, this type of experiment can be expanded in other areas also, and we can do this type of partnership with the stakeholders at the district level, at the tehsil level or taluka level, and we can do a great job because you need to have a supply chain. The sample can be collected from the village or from the smaller areas, and they can be processed at the district hospital, and we can use the technology, smartphone or the AI as Sir was discussing, and we can get the report same day or the next day. So this is very important that we use the technology, we use all these resources, and we use the private partner, because the motive of the private, most of these labs operated by the private partners, they initially we have seen that RT-PCR cost was 4,500, and now RT-PCR cost coming to 250. See the difference. So this quality is very important. The pricing is very important, and we have the multiple partners to give the best care in the rural area, and we must have the good team to be prepared for the future pandemic. This is the key message for this discussion. Thank you.
So there you have it, very well-rounded and a very set of eminent speakers. I would request all of you to kindly put your hands together for a round of applause. You covered the entire gambit from medical education to policy to really private delivery, public hospitals, Indian medical clinic, the clinical aspect of healthcare delivery. So it's a very well-rounded, eminent panel. My organizers tell me we are at the end of time, and some of the speakers would have to catch a flight. But I think many of us would be around if there's any questions you have. But we won't, for the interest of time, take at this time any questions. I would like to end this session by saying that the entire gambit that is covered here was from healthcare infrastructure to deal with the emergency. And to deal with a global emergency particularly, you require a multi-pronged approach. And the speakers talked about the way to boost the healthcare delivery capacity in short time, talked about digital health, talked about the need for rapid innovations. We didn't talk a lot about startups. They have a major role to play along with industry in this. The need for global collaboration, national collaborations in terms of information sharing, and broad public health and health system strengthening in an environment of good public-private partnerships and a favorable policy and regulatory set or a framework that is well bound around transparent and a data-driven governance. There are many of these areas which you can go and talk about hours and hours about. But I would like to end this session by thanking each of the speakers who presented their thoughts and ideas. And again, I would like to thank Economic Times for choosing this theme in recognizing the doctors and the entire supporting staff, including nurses and allied health workers. And to all of you who are doctors here, our sincere debt of gratitude for all you do. Thank you so much. Over to the organizers.